Good day, everyone. Thank you for joining the RNAO CPG Implementation Webinar Series. I'm Irma-Jean Bainoff, the Director of International Affairs and Best Practice Guidelines Programs, and today I'm joined by Heather McConnell, the Associate Director of the International Affairs and Best Practice Guidelines Center. Actually, we're a center, as well as Catherine Butler, who is the Senior Director of Practice at VON Canada. And today, as we have done in the past, we want to present to you some background information about RNAO, as well as the guideline development process and the guideline that has started this all, which is caring for patients who have the diagnosis of diabetic foot ulcer. We present a set of content and always have an opportunity for application through the joining in of one of our Spotlight organization members who will share with us how they've actually applied the content. So let me move in quickly to just give a quick summary. The Registered Nurses Association of Ontario, we're the professional association of registered nurses in Ontario. We are the voice for professional nursing that speaks out for quality nursing and quality health care, promoting healthy public policy and clinical excellence. The Best Practice Guideline Program is a key program of RNAO and is really the main vehicle through which we influence clinical excellence. The BPG program is very linked to the Council of the Federation, and it's through this means that we come to you today. The Council of the Federation, as you may know, has chosen to focus on three particular areas in healthcare, one of which is clinical practice guidelines. And the Council of the Federation, as I'm sure many of you know, is the collection of premiers from the provinces and territories who have chosen to look at healthcare issues in the absence of renewing the Health Accord. RNAO has worked along with the Canadian Nurses Association and the Canadian Medical Association in relation to selecting CPGs for national implementation. The working group has developed criteria for which guidelines will be selected, and for 2012-2013 chose the C-Change guideline, a guideline focused on cardiovascular disease, and the RNAO guideline, care of patients with diabetic foot ulcers. Because RNAO has a great interest, involvement, and skill in the whole area of implementation, we have been asked to share with you our knowledge and resources related to implementing CPGs. And as such, we have started the national webinar series related to implementation. The next slide just quickly tells you what the webinar series has focused on to date. We're here today at number 5, talking about gap analysis as a first step in guideline implementation. And our next webinar, which will be in August, is on evaluation, and then the September webinar will be focused on nursing order sets. And we will continue the series on absolutely until the end of the year and beyond, and our next range of topics will be posted soon. As I mentioned today, we're reviewing the guideline, and we'll be looking specifically at gap analysis. We have a change in focus today in that we're going to hear from the field first. So Catherine Butler will be sharing her experience from the field in using the gap analysis process, And then Heather McConnell will use that as a case study, if you will, to go through the theoretical component of what is a gap analysis and why it's important. And then, of course, we'll have questions and discussion in the time remaining. Just a very brief highlight of the International Affairs and Best Practice Guideline Center. Our mandate is developing, disseminating, supporting the uptake of clinical and healthy work environment best practice guidelines, as well as evaluating their impact on outcomes. We've been funded by the Ministry of Health and Long-Term Care for some 13 years now, and we're absolutely delighted with the support, and the ministry is delighted with the widespread use of the guidelines and the outcomes for practitioners, clients, and the system. You can see the next slide has the model of our program. I will not get into it in any detail, but suffice to say that we have a very rigorous guideline development process, a 7-step process that does include reviewing and revising in second editions each of the guidelines. And case in point is our diabetic foot ulcer guideline, which is the second edition, which has recently been published. We do have 9 healthy work environment guidelines and 39 clinical guidelines. We pay as much attention to deployment and implementation as we do to guideline development, hence our interest in these webinars, and as well are very keen about monitoring and evaluating the impact of these guidelines for patients in particular, but also for providers and the healthcare system. If, in fact, the guidelines are not having the desired outcomes, then we absolutely need to go back to the drawing board. The goals of the Best Practice Guideline Program are very much related to improving health care. And we found that with guideline use, what happens is we're bringing that best evidence from the research into the heads and the hearts and hands of nurses and other healthcare providers. We're conveying the knowledge base of nursing, of course assisting with clinical decision making. And when guidelines are developed, we identify gaps in research. Now, when a guideline is used, number one, it reduces the variation in care. When a team, an organization, a system chooses to use a particular evidence-based guideline, the variation in care is reduced. And in fact, that is what contributes to health outcomes being met in a more timely manner, and of course, costs being reduced. Guidelines also help us stop interventions that have little effect or, in fact, cause harm. So all of those become the goals of the program. The diabetic foot ulcer guideline was developed really to address how we can assess and manage those individuals who have a diagnosis of diabetic foot ulcer. So the recommendations that the guideline produces are all evidence-based, and the focus is for folks who are greater than 15 years of age with type 1 and or type 2 diabetes, who already have a foot ulcer. This is not a guideline necessarily on prevention. We do have other guidelines that address prevention. So to let you know, the team that's developed this guideline is an expert panel led by Laura Teague, clinical nurse specialist at St. Mike's, who has as her area of focus wound care and in particular diabetic foot ulcer care. You can see the panel member there. It consisted of nurses, physicians, chiropodists, other members of the health team, as well as a group of RNAO staff that involved our program managers taking a lead in guideline development, as well as our research associates taking the lead in the systematic review process. All of the guidelines also have stakeholder reviewers, and this guideline is no exception. A team of stakeholder reviewers helped us sharpen the guideline. You can see the research questions that led the, or directed the systematic review, looking at assessment of foot ulcers, secondly, managing and preventing re-ulceration, and then looking at the education and training for healthcare professionals so they can have the capacity to do this work. And then lastly, what needs to be in the healthcare organization's policy, practices, resource base to support guideline use. And moving on to our recommendations, I've mentioned them a few times. There are 19 practice recommendations following along the practice methodology of assessment, planning, implementation, and evaluation, 2 education recommendations, and 5 organizational and policy recommendations, very much linked back to those research questions. Then looking at the practice recommendations, I'm not going to go into these by any means in detail, but you can see that the 8 related to assessment really start with the comprehensive health history all the way to looking much more granularly at the location of the foot ulcer, the actual characteristics of that foot ulcer, and then moving on into the next set of recommendations, looking at vascular supply, looking at clinical assessment techniques, and then looking for sensory, autonomic, and motor changes. So the assessment recommendations are very specific to what the practitioner is doing on site. And then again, the last 2 recommendations here under assessment, focusing on assessing the affected limbs for deformities, ability to exercise, gait, and then finally documentation. So those are all the assessment, which is very critical in this particular guideline. The planning recommendations, looking at very much making the judgment of the potential of the ulcer to heal, developing the plan of care, and here's where we're very much focusing on the involvement of the client. This ends up being a chronic disease in many instances, and client involvement, client-centered teaching, self-care are very critical. And then the next 2 planning recommendations are looking at working with the client, family, and interprofessional team, and then developing mutually agreed upon goals. And here's where those kinds of plans have to be made about what can we do if, in fact, this ulcer does not have the potential for healing. We hope always that we can bring this to resolution, but that is an issue that needs to be discussed. Implementation are all those areas that we look at oops, I moved too fast, that help one implement that plan of care, very specific around debridement, the redistribution of pressure, health education, and client-centered learning. The evaluation recommendations are next, which involve an ongoing monitoring of the wound healing, and then reassessing for additional factors that are necessary if wound healing doesn't occur at the expected rate. So that's a very quick overview of the guideline and the recommendations. And what I would say then is when we talk about actually implementing this guideline, it's important then that those implementing take the guideline, in particular the practice recommendations, and really do a hard look at their own practice. and identify what's happening and what isn't happening and what to do from there. And that begins really what we call a gap analysis. And it's a way to say, you know, here's a place to start. So I really am delighted now to introduce to you Catherine Butler from VON Canada. And Catherine, as I mentioned, is the Senior Director of Practice. And VON Canada is one of our founding Best Practice Spotlight organization. They've been a spotlight now since 2003. And as you know, in home health care, wound care, and in particular diabetic foot ulcers are a major part of the practice. So I'm going to turn things over to you now, Catherine, to give us the field view, and then Heather McConnell will put the theory around what you're sharing. Catherine, are you there, and can you go ahead?
Yes, I am. Can you hear me?
We can hear.
Okay. So I'm assuming there's no problems with the microphone.
You're coming beautifully.
Oh, great, perfect. I've got the volume. I can see you're turning the volume down. Great. Well, thank you very much, Imogen. I very much appreciate this opportunity to be able to, you know, talk about how BPGs are implemented in organizations at a very practical frontline level, I guess, for lack of another phrase. Although I guess I want to set some context first before I start talking specifically about our focus on the gap analysis, and that is that when I talk about today about the BPG in terms of the assessment and management of foot ulcers for clients with diabetes, we use this BPG in many of our different programs because we do a lot of wound care. It's used extensively in our wound care program, and we've actually also used this BPG quite extensively in our recent overhaul of our wound care practices to align with outcome-based care initiatives in Ontario. But what I'm actually going to focus on a very specific area that it's not solely wound care, but it came up and this BPG turned out to be very valuable as we were reviewing our foot care practices. And foot care, if there's any of you that are in home care, community care, the context behind it is that this is not necessarily an ongoing consistent practice that we do with folks in their homes. A lot of our foot care is provided in a clinic type of environment where clients come to us on their own accord, or they're referred by their primary care providers, or we do some foot care in the home, but we're not necessarily the first or foremost contact or organization that's in that particular circle of care for the client. So I say that and give you a bit of context because you will understand how some of these recommendations needed to be looked at in terms of the perspective of the type of services that we were offering and how we could offer the best quality of care to the clients in the foot care program that we had. So is it possible to advance to the next slide? I think. So I talked a little bit about the context, but what I wanted to share with you in terms of the practicalities is that we have, again, a fairly large foot care program. Most of our 50-plus sites in Canada do some level of foot care with clients. Most of our clients are elderly, and many of them do have either type 1 or type 2 diabetes. So we recognized that the last review we had been quite a few years ago, and we needed to actually review and revise the clinical protocols, everything from the assessment piece to the planning piece of foot care in a way that promoted consistency across the board in terms of practice, and that was based on best practice. So we, clearly we knew about this particular best practice guideline. We also knew that it had not been extensively incorporated into the program overall. So we were able to pull that BPG out and begin looking at the recommendations. and we really wanted to ensure that it was the core guidance for us in terms of the appropriate management of foot care clients with diabetes. And as the rest of this presentation is going to talk about, one of the most important considerations for us in terms of implementing this guideline began with the gap analysis. We needed to be able to have a good understanding of where we were currently in our own foot care practice. If you could advance the slide, or can I do that myself, actually? Sorry. So the gap analysis, we used the gap analysis tool as part of the toolkit, the BPG toolkit, in order to help us develop a process to use. And we started by looking at organizationally across the board an internal scan that helped us collect forms used for documentation of foot care. What did we have out there, and how consistent was it? And what we found was that even though there were some centralized forms, a lot of them had been changed to suit local specific needs. So there was a lot of inconsistency that had developed in the last several years since the last review. We also needed to understand how our nurses were being educated to develop and understand their own competencies related to foot care. And we didn't have a lot of faith that there was a consistency in that either, and we were correct. We wanted to know what learning packages and teaching plans were in place across the organization, as well as the various foot care leads that we had in the site, who they were, what their current knowledge base was, and what resources that they were pulling into the education and knowledge sharing that they were doing with other nurses practicing foot care. And then, in general, we wanted to really get a good, strong perspective on what current foot care practices were in that direct relationship with the client. Now, because we're a national organization and we have sites all over Canada, it wasn't always possible to do that direct observation process. So a lot of this we did through chart audit. We interviewed foot care nurses that were providing foot care. We interviewed foot care leads in terms of finding out exactly what they did and their rationale behind it. So we were quite extensive in that gap analysis that we did. The next step that we took was to, I'm just trying to move it ahead and I can't move the slide. Sorry, folks, I'm just, I know that the presenter was handed to me. Thank you. So the next step that we did, so originally we took that DPG, we did a really great, thorough, overarching review. We took that DPG again and we started looking at the recommendations to determine where the gaps in practice existed. And again, that was based on that assessment of current practice. We identified which recommendations were not applicable, and I didn't list them here. I didn't focus a lot on the recommendations themselves because it would have pulled us into a lot of detail that I don't think helps understand how we used it. But in alignment with the context of the type of foot care that we provide, the environment that we provided in, and that continuity of care that the limitations on the continuity of care, we looked at the recommendations that were not applicable and kind of knew that that was not going to be our area of focus, and we really looked at which were the recommendations that made the most sense to the program in terms of enhancing the quality of care provided to the client, and the ones that would really help us most likely see the best outcomes. So we really focused first on building alignment. So we looked at the changes that could be implemented easily within those recommendations, and this is how we developed, moving from a gap analysis into developing a process map or a plan of action in terms of how we were going to go about doing this and changing the program. We identified the ones that could be implemented easily with the resources that we had and that we could be able to start working on immediately. We really tried to align changes with organizational priorities where possible to create broader support for recommendations. So, for example, where those sites are that had larger foot care programs and really served a larger client base, we looked at starting with the education and tapping into those sites to be able to provide support and begin working with them to change their practices as quickly as possible. At the same time, while developing a national database of tools and processes that any site that has foot care programs could use. The third part of that was identifying resource requirements for the longer-term changes. Next slide. So based on the gap analysis that we did do, it made sense for us organizationally and for our clients and nurses that we started with a revision of all education material that was based on the recommendations, as many of those recommendations as were applicable to our practice. We revised the forms that we use. So one of the great things that my team worked on in terms of the forms was that we really wanted to find a way to cue nursing practice in alignment with the VPG, with that particular VPG. So, for example, focusing on the signs and symptoms, a 9-point monofilament test, client self-care knowledge, and this is something new that we hadn't done before. And a part of that comes from the challenges in organizations trying to reach a nursing labor force that's dispersed across a large geography, and in which there's resource challenges trying to get those nurses together to do any of that education. So in addition to education, we try and build in queuing to those assessment forms where we possibly can. We added a care plan to the flow sheet as well, which is a key part of the recommendations. We actually didn't, I wouldn't say we didn't have a care plan previous to this, but it certainly wasn't used consistently, and it certainly wasn't based on the best and most current evidence given our assessment. Some of the other pieces that we did a lot of revisions to the documentation and the education that were aligned with the recommendations. And again, they were national in scope. A critical factor that we identified in the gap analysis was the lack of consistency across the board in the practices of the various nurses in the foot care programs that we had. Some were quite current in their knowledge and really understood some of the core pieces of the DPG recommendation. Others, it was clear, needed a lot of support in that area. And so through the tools, through that gap analysis, we were really able to build consistency in processes, in the tools that we use to support nurses learning. And we're seeing that evidence now and consistency in terms of how our nurses are prepared to provide foot care at both basic and advanced levels. So the education tools and the education program we've developed, very much in alignment with the DPG recommendations, means that every nurse that's that comes into service as DON, or any nurse that's in a current foot care program is required to either review this education or take it in the first place in order to ensure that they're using the same tools, they're using the same processes, and that there is consistency. It's building a consistent base of skills in the foot care educator group. Part of this was developing almost a community of practice for our foot care educators to have discussion, to do some of the education so that they themselves, in their approach to consistent education and teaching, are promoting consistency in practice within the clinics and the program. And it's really, we're also really noticing consistency in how practice is carried out and documented. In terms of the evaluation piece of this, I guess that's a story yet to come because we've just really implemented all of this recently, and we're planning on going back and evaluating through more direct observation and chart audits to find out where the changes are happening, what types of outcomes that we're seeing, and how much that consistency is evident now vis-a-vis what it was earlier on in the program. So I guess in a nutshell, that's really how I wanted to emphasize the gap analysis piece because it was so critical in terms of us determining what our priorities were for this particular program and how we moved forward with it. So I'll stop for a moment and ask if anyone has any questions. I think we have a moment. I don't know.
That's fantastic, Catherine. And yes, I have to tell the group that Catherine unfortunately does have to leave shortly, but obviously you're offering to spend a little time for questions. So if there are any questions directly to Catherine, we're happy to take them now with the understanding that Heather will carry on with some of the content around how exactly you do this. So I wonder if you could type your questions or
Irma Jean, the other option as well is that if folks don't have a question offhand but want to ask one later, I am more than happy. I can type in my email address, and I am more than happy to take them after the fact and provide people with the information that I can.
Yes, and also we're happy to direct questions. That's always an option. Now, I'm not sure what this question is. It says, please repeat what all foot care nurses would have to read to be consistent with the BPG.
I guess maybe what I would say to that is that when they come, when foot care nurses begin with our program or are providing foot care, they are required to go through a revised education process that includes all of the background information. It includes all of the directions and support around the assessment pieces, around advancing. It's focused on advancing skill development. So there's a package, I guess, for lack of a better word, that everyone is required to use and to participate in prior to performing foot care, being able to perform foot care as a DON nurse. And that's in addition to them coming to the program. Usually most folks, when they're starting foot care, already have either an internal or external foot care program or certificate knowledge of some kind from an outside course they've taken. So this would be expected in addition to that, because we want to ensure that all of our nurses are practicing in as closely in alignment with the BPG recommendations as possible.
And I think that's very good to reinforce the notion of reducing the variability of care. Now, there's another question: who provides the education process?
We actually have a core number of foot care educators in the organization. We have clinical educators in different sites, and we have 2 clinical educators nationally that help develop the material. And then we have specialists in foot care who actually provide foot care education.
And again, I reinforce that in home care nursing, this is a huge area of your practice. But also across this country, we're finding it a huge problem that is affecting quality of life as well as cost. Now, there's another question. I can't see the top of it. Okay. Is there a cost to the client to receive foot care? If so, what is the approximate cost?
Usually there is a cost to the client because foot care is one of those areas, I guess depending on where you are in the country, what province and jurisdiction you're in, it's quite dependent on whether or not there is any type of funding for foot care. I can't tell you what the cost is. It's actually different from province to province and jurisdiction to jurisdiction. If you are very interested in finding that out, I could certainly give you some type of average cost. I would just have to do some research on that.
Mm-hmm. Okay, thank you. And I think, again, that reinforces that depending on the kind of health plan one has in their province, and where home care is in terms of our publicly funded not-for-profit healthcare system. Any other questions before Catherine will have to leave?
Irma Jean, somebody actually emailed me just to ask me about baseline outcome data.
Okay.
And they asked if we had any for comparison, and we don't. And I will be very, very honest with you. That was a huge part of what we identified in the gap analysis was the lack of consistency very much so, in measuring wound beds and doing a measurement. Sometimes it's challenging. It has been challenging, I think, to do that in foot care environments before because of the inconsistent ways people were charting and assessing. Where I think we're really going to see some strength in that is perhaps not even so much the foot care program as we're going to see it in our wound care program that is very much outcomes based going forward, and we're going to be able to hopefully take some of those learnings and apply them to the foot care program, so that we're increasing our ability to measure outcomes in the foot care program as well.
The one point I would also make in relation to that is within the guideline, in the evaluation and monitoring section, there are a list of indicators that could be used for measurement of outcomes of this work, but I know you'd be looking at number of days on service, length of time to heal, reoccurrence rates, all of those pieces. We do have one more question that asks, how frequently is the chart audit? And this is from one of our BPSOs in Colombia, South America.
We haven't had a specific regular, I guess, process for doing chart audits previously. But going forward, when we start looking at this and when we do our evaluation, we would do a chart audit most likely on a quarterly basis to look at changes over time in probably, I would say, a year period, an annual period would be a good comparative time frame.
Okay, great, thank you. And I would also just remind those of you who are spotlight organizations that Enquire, which is our evaluation system, Nursing Quality Indicators for Reporting and Evaluation, does enable spotlights to enter baseline data around key indicators related to this guideline, and then follow-up monitoring with data submitted on a regular basis. Depending on the indicator, it may be more, maybe monthly, maybe quarterly, etc. So with the work that we're doing with spotlights, we are building in ways to monitor outcomes through the indicators. So I'm going to, at this point, thank you very, very much, Catherine. That was really very helpful and a wonderful way of giving us the information right from the field. Right now, I'll turn things over to Heather McConnell, who will just now look at implementation and how the gap analysis fits into the implementation framework and give us the full details. Thank you, Catherine, and here you go, Heather.
Great, thanks so much, Imogene, and thank you to you, Catherine, again for bringing the lessons from the field as most helpful. What I'd like to talk a little bit about now is RNAO's framework for guideline implementation, and this framework is really well described in our toolkit, Implementation of Clinical Practice Guidelines, which is was published in September of last year and is available for free download on our website in both English and French. Now, this toolkit really does guide much of the work that we do in relationship to our Best Practice Champions Network, our Best Practice Spotlight organizations, and much of the professional development offerings we have related to guideline implementation. If you are interested, we do have an archived webinar from our April webinar focusing on the use of the toolkit. But what I'd like to talk about now is the framework specifically, the knowledge to action framework that was utilized in the toolkit to be able to actually guide the development of the chapters. So you'll see here that the knowledge to action framework adapted from Graham et al. Really focuses on the area of knowledge creation, which is the central component of the framework, really looking at knowledge inquiry, knowledge synthesis, and knowledge tools, which of course would be a best practice guideline. And then once the guidelines are available, and we know that the first step is really to identify, review, and select the knowledge. Well, in the case that we're using today, of course, the Council of the Federation has gone through a process of critical appraisal of existing guidelines, looking to see which ones will have the biggest impact for the country, etc. And as Imogene mentioned earlier, have selected this particular guideline on the assessment and management of foot ulcers with people with diabetes as the guideline of choice. Now, within that, however, there is a need for organizations to really focus on what specific practices are they currently involved with and what practices need to be adapted or modified or enhanced to be able to meet the best evidence. So the chapter 1 of the toolkit really focuses on this whole area of identifying, reviewing, and selecting knowledge. And of course, part of that involves the actual content of a gap analysis. Just to put this into some context, I'll just review some of the other elements of the knowledge to action framework. So going from the bottom of the model up the left-hand side, looking at adapting knowledge to the local context. So recognizing that the implementation, the knowledge used potentially in a home healthcare situation, which we've just heard about, might look very different from what it might be in an acute care hospital where they're providing wound care services and surgeries to clients with diabetic foot ulcers. Also up at the top left-hand corner of the model, looking at assessing barriers and supports to knowledge use, the need to be able to select, tailor, implement the interventions, monitor the knowledge use, and of course the evaluation component is so important, not only at the use of the knowledge, but also evaluating the outcomes, and then being able to focus on sustaining knowledge use. So this is the model that frames the toolkit, and the gap analysis, as I mentioned earlier, really focuses on that first chapter, identifying, review, and selecting knowledge. So again, we're looking here at the gap between current practice and recommended practice. And the BPG implementation teams within your organizations that have the responsibility for really leading the practice change forward will benefit by measuring the evidence to practice gap. And here what we're really talking about is the gap that exists between evidence-based clinical recommendations that are described in high-quality clinical practice guidelines and current practice within the organization. So really trying to get a sense of what the difference is between what the current evidence says and what the current practice actually is. And of course, this is identified through a gap analysis. And so when you're looking at these types of things and you're wanting to start a gap analysis, it's very useful to engage point-of-care practitioners in this, and certainly we'll talk a little bit more about this shortly, and ask the questions, are there gaps between current practice and best practice, and where and to what extent do the gaps actually exist? So in terms of just a definition of a gap analysis, it's a process by which the implementation team determines what guideline recommendations are currently being implemented and supported in practice. And this information can be used to reinforce practice strengths. And of course, that's certainly an area that we want to highlight to your teams when you are doing a gap analysis, that they'll be doing many things already in their practice that are reflective of evidence-based practices. And you really want to make sure that you can celebrate those with staff. And it's always good to start the process by saying we're doing these things really well. A gap analysis can also identify which guideline recommendations are currently being partially implemented in practice. So those areas where things are underway in terms of focused evidence-based practices, but there may be opportunities then to enhance the existing practice. And these, of course, would be good first targets for change efforts. And then what guideline recommendations are currently not being met at all and may require longer-term practice change strategies. And certainly it is important to be able to identify what practices are not actually evidence-based within your organizations and make some decisions about how you're either going to approach those practices to be able to enhance them to become evidence-based. Certainly you also are able to identify current practices that are contrary to the recommendations, so things that you might be doing in your practice that are not consistent with evidence-based practice or may in fact actually be harmful. And then of course those guideline recommendations that are not applicable to your particular practice setting. And Catherine did mention when she was discussing her experience at the VO in Canada that there were some recommendations within the guideline that really didn't fit with their practice area, but they focused on those that did. So in terms of conducting a gap analysis, there's a number of steps to go through, and I'm going to speak to this briefly to give you the real sense that this is a logical, thoughtful process that you need to go through in terms of being able to identify where to get started. So there are some key questions that direct how and where the guideline will be implemented. And so again, what is our current practice? Is it known and is it consistent? And I think we've heard from Catherine that there was some need to be able to get a sense of what the practice was across the country and whether it was consistent or not. And I think from VO in Canada, they found that that was an area that they wanted to enhance? Are there recommendations that are already being implemented? Are there some that have only been implemented partially? Only certain recommendations, only on some units. So you may be reflecting, thinking about those practice recommendations Imogene mentioned earlier. Certainly there may be some departments that are more involved in this particular area than others. What is the consistency across the organization? Are there some recommendations that must be implemented before others? Is there a sequence that's necessary for us to be able to reflect on before we get started with guideline implementation? Can any recommendations be implemented quickly? Will some recommendations take longer than others to implement? And of course, it makes sense to try and start with those that can be moved forward more quickly. Are there specific recommendations that are a higher level of evidence than others that you might want to consider? Are there barriers to implementation? Are there issues related to budget? Catherine spoke about some of the resource implications. Staff skill issues. Again, do you have consistency with your staff education and support? Are there leadership issues, workload issues, or cultural and attitudinal issues? So all of these things will surface through asking some of these questions. It's really important when you're conducting a gap analysis to engage your team. And you want to involve all those at the point of care who can describe the current common practices in relation to the specific topic of the guideline. So as Catherine indicated, they had an opportunity to actually do interviews and consult with some of their foot care leads in the organization across the country to really get a sense of what is actually happening on the ground, what is really happening in practice. Involve other stakeholders for recommendations related to referral or interventions that involve other members of the interprofessional team. So again, really wanting to ensure that you get a broad input from a variety of different key stakeholders from different perspectives about the process of what's happening within your organization. It's also important and possible at this stage to involve patients and families. What are their experiences? What are they finding in terms of the care that's being provided in the organization? And what might they recommend in terms of some first steps? And then, of course, to involve external stakeholders as necessary and appropriate. Now, you can certainly get use a range of sources to inform your gap analysis. And there's a number of sources of information that is listed here on this particular slide. I did want to just reinforce that when Catherine was speaking, she spoke about looking at their documentation forms, what was currently on the forms. They looked at the existing competency education matrix and the resources that were available for educational materials. They looked at learning packages and what were consistently in those. As I mentioned earlier, they interviewed current foot care leads and really got a sense of what was happening with the work that they were doing. And of course, having chart audits and really looking to see what practices were being conducted and being documented. So when you're looking at a gap analysis, think quite broadly about where you might get the information to inform your assessment and utilize a variety of sources that make most sense for you and your team. Now, this is just an example of a gap analysis tool that we populated with the practice recommendations focusing on assessment from the diabetic foot ulcer guideline. And you can see that this is really quite a simple tool in terms of being able to identify whether the recommendation has been met, partially met, or unmet, and then the comments. But this summary really is reflective of all of the previous work that you've done in terms of being able to speak with colleagues, ask those critical questions, get a sense of where your organization actually is within the implementation of the guideline so that you can have a very good sense of where you're going to start your implementation efforts. So again, focusing on needed practice change. Not all practice will change when implementing a new clinical practice guideline. And just really wanted to reinforce that, as Catherine indicated when she spoke, that there were some critical areas that they wanted to focus on, but it's not necessary to have a big upheaval of everything. You want to celebrate and provide, recognize that guidelines provide support for current practice and direction for practice improvement. It's critical to examine current practice and compare it to the guideline recommendations. And then implementation can then be directed towards reinforcing and sustaining existing best practices and targeting specific areas for practice improvement. So using the gap analysis results, well, after you've done all this work, what are we going to do with this information? Well, certainly the gap analysis can really help explain where the practice environment stands currently compared to the evidence-based recommendations. It provides an in-depth look at the where and why of current practices, as well as the who and how to make what kind of changes you've identified as being necessary. It provides also a summary of practice processes that comes from a range of sources. So again, really a convenient document that provides a summary of the activities going on within your organization. And it also allows you to demonstrate progress in implementing a guideline if you use it in a planned and thoughtful way throughout the guideline implementation process, and actually be used as part of the tools that you use to track your implementation efforts. But gap analysis can also inform your next steps. So it can help with the development of an infrastructure to support your implementation activities. Obviously, it initiates a whole focus on stakeholder engagement. It can certainly help identify facilitators and existing barriers within the organization as you're reflecting on the existing practices, what things might get in the way of making changes to those. As Catherine spoke earlier, really helping to identify resource requirements for longer-term changes. It also can help you start thinking about the selection of the implementation strategy that you're going to use as you're reflecting on where the current gaps are and what the current services and supports are within the organization. And then as well, you can start thinking at this stage, recognizing from these various different information and data sources that you use to inform your gap analysis, and that can also link back to approaches that you might want to consider for evaluation. And certainly Catherine spoke to that. But gap analysis can also lead to sustained practice change. And you recall that when I went through the framework at the beginning of my part of this presentation, one of the last things that I mentioned was a focus on sustaining and monitoring sustained practice change. But certainly by the fact that you've gone through a thoughtful gap analysis process, it really does help engage staff in identifying what has to change. It helps support buy-in from the frontline staff members, which really then impacts in the long term in terms of their ability and interest in supporting the long-term change of practice that's required. It reinforces what evidence-based practices are already being carried out. So again, those are the ones that we want to sustain for the long term. And the gap analysis also leads to informing your sustainability plan related to the processes that you currently have within your organization, the staff supports that you require within your organization, and then of course organizational structures that might need to be in place to help sustain practice change over time. So the early time that you spend in conducting a thorough and thoughtful gap analysis really does impact dramatically on all aspects of the knowledge to action framework. And at this time, I'll turn it over to Ernestine.
Well, Heather, thank you very much. That was a packed 15 minutes, I must say. So you've now had the opportunity to hear both the field example of a gap analysis and then the theory around it related to implementation. So I'm going to open the lines now for questions about this as a beginning step in implementation. Are there any questions? We've got some minutes. I think you're all typing. We understand people are typing in the questions. I guess I would have a question while you're typing there, Heather. If you could have a sense of how much time should an organization allot to carry out this kind of a process in the beginning steps?
That's a great question, Imogene, and I think much of that will be dependent, of course, on the size of the organization and the scope of the work that we're wanting to do. But the time that you spend up front in doing a thoughtful gap analysis, using that to inform your implementation plan, and then being able to use it to monitor on the ongoing basis is really quite important. So we're looking at several months to do this, and then again, recognizing that you may need to come back and revisit your gap analysis as you move forward to identify where you're actually now meeting specific recommendations or where you need to continue to make major efforts to help meet those unmet recommendations. So I'd say it's not a one-time thing. It's something that you need to revisit.
Excellent. And important to spend the time up front. Now, I see a question that says, is it possible to use the gap analysis process when implementing a practice change that's not specific to a BPG? And absolutely, the answer is yes. In fact, the implementation toolkit as a whole is useful for practice change. The thing you need to keep in mind, though, when you're doing a gap analysis is you need to have a set of information that tells you where you want to go. And the where you want to go in guidelines is very clearly spelled out in evidence-based recommendations, which tells a clear message to your practitioners as to what will be the interventions, and also provides a credible message in that you've got the solid evidence behind it. So now, Heather, if you want to add anything to that.
Well, I think you've covered that nicely, Imogene, in terms of recognizing that the process and certainly the toolkit can be used for a variety of different activities. But as you said, you want to really have a clear picture of what your final vision is or the outcome that you want to achieve, whether that be guideline recommendations or other.
So here we have another question. How many people are required on your team to ensure successful implementation? You mean implementation of the gap analysis? I presume. Well, let's start with that.
Well, again, I think much depends on the scope of the work that you're doing, the size of your organization, the number of units that you're considering implementing a guideline on. I think what's really important when you're looking at implementation is that the broader your stakeholder group can, the broader the stakeholder group you can engage at the beginning, the more impact that will have as you're going through your planning process. So I don't have a magic number of the number of people that should be on your implementation team, but I would recommend that you have good, solid representation from those frontline clinicians who are actually going to need to implement the practice changes within their daily work. And that would include multiple disciplines as well as other key stakeholders that might be specific for a particular aspect of the guideline that you're implementing. So that might include having some content or input from some of your environmental services people or some of your those that order supplies and equipment, do the contracting, et cetera. They may not sit on your implementation team, but they need to be involved in some of the discussions that you have related to their particular area of interest.
And I think the critical thing is maybe it's not so much the number, but have you actually engaged all the critical stakeholder types? And that reminds me that in the fall, one of our webinars will be on stakeholder analysis because that is such a critical piece of this work. Are there other questions? Just back to that number of people on your team, if you remember from Catherine, she clearly involved a number of key stakeholders and definitely a number of the leads who were involved in actually delivering foot care. Any other questions? If not, I see our time is 1 o'clock, and I would just remind you all to visit the RNAO website. Up there on the screen, www.rnao.ca/ppg. If you wish to access the guideline, it's freely downloadable. You can get more details regarding our implementation resources. In addition, you can access the guideline implementation toolkit, again, free of charge. And then there is access to the archived presentations from this webinar series, and I recommend you contact Andrea Stubbs, the email there. Our next webinar series will be on August the 29th, Evaluating Nursing and Client Outcomes Through Guideline-Based Indicators, and we will be talking about the RNAO Enquire Nursing Quality Indicators for Reporting and Evaluation initiative. So until August 29th, I'll say thank you for joining us and just reinforce that we're delighted to have so many of you on the line from across Canada and indeed around the world. So thank you and good afternoon or good morning or good evening. Bye-bye.